Welcome to GN in 10, a bite-sized podcast brought to you by the International Society of Glomerular Disease. Our hosts are nephrologists and glomerular disease experts, Dr. Kenar Jhaveri of Northwell Health and Hofstra University on Long Island, New York, and Dr. Koyal Jain from the University of North Carolina, Chapel Hill.
All right, everybody, welcome to GN in 10 NephMadness episode. And the topic today is IgA nephropathy. It's just another IgA talk. You've probably heard so many of these, but this is going to be a NephMadness one. It's a little bit of competition here. We have Ali here, one of the fellows, and Matt Sparks joining us. Can you guys introduce yourselves? Oh, I forgot to introduce Koyal again.
Everybody forgets about me. Don't worry, I will end this with a bang.
Oh, gosh. Here with the compliment cascade. Okay, let's do it.
Hi, everyone. I'm Ali. I'm a second-year nephrology fellow at Duke University. Thanks for having me today.
And before we go to Matt, though, Ali was one of our medical students at UNC. And so I've known her a very long time, and I'm so glad that she's here on the podcast.
Full circle moment. I love this.
We're very friendly, and it might appear that we have rivalry on the basketball court, but in nephrology,
Not in
we love
clinic.
each other. Yeah, in nephrology, we are banded together to take care of patients with kidney disease. So I'm Matt Sparks, I'm the program director at Duke, and I'm also one of the co-creators of NephMadness and on the executive team. I'm proud that we're in our 14th year, and just as Kenar mentioned, we've covered IgA frequently. I think just 2 years ago, and it's just so many things happening, we felt like we had to go back again.
We'll probably be back in 2 years as well.
Can I tell you, I feel so validated with this write-up. When I saw the two topics, which were BAFF-APRIL versus B-cell modulators versus complement inhibitors, I feel so good because the last time when we were voting on this, I said that it would be one of the immunosuppressive agents, but everybody voted for the DRAs and the non-immunosuppressive. And so now I feel so good.
It's all
that we're
immunosuppression.
I think it's about time nephrology goes to ACE last and not ACE first, because I think we're not treating the disease, just the downstream fibrosis all the time. And that's where you go first for that rather than second. So I'm glad you're putting immunosuppressions up in the map right now rather than these ACE-ARB, SGLT2. Those are fine, but they should be the last thing you put on the patient, not the first thing. I think the immunosuppression or chemo should be first for targeted therapies. So with that, IgA, just another talk. We have, 19 drugs approved for IgA somewhere around the world.
Another one today, actually.
Yeah, probably.
No, just kidding. It actually is not.
It's like the England Journal of IgA these days.
England Journal of IgA. I like that.
So we have these chronic drugs that are for more CKD, like the SGLT2s, the ARBs, the endothelin antagonists, and maybe MRAs will come there soon, and GLP-1s, I'm sure. Despite that, we have the immune mechanism that triggers IgA, the four-hit hypothesis, and even some people even call it the zero-hit. But the four drugs there are really your steroids, your budesonide, and then you have the two new kids, which you guys are going to talk about, is the complement inhibitors and the APRIL BAFF inhibitors. Let's maybe start with the four-hit hypothesis, and maybe you can just remind people about that, and then go into the two kids on the block.
So pathophysiology of IgA, four-hit hypothesis. One, you have your production of galactose-deficient IgA. Then you have production of IgG and IgA antibodies against this galactose-deficient IgA. And then these all form immune complexes containing IgA, IgG, galactose-deficient IgA, and ultimately hit 4 is that these deposit in the mesangium of your glomerulus, causing kidney damage and disease.
One of the things that has come up is how does complement play a role with IgA and all these new agents that we're talking about, the two groups that we'll actually talk about, the B-cell modulators, which is like BAFF, APRIL agents, and then complement inhibitors, how are they playing a role?
I think, as Kenar alluded to, I think we're really starting to get more upstream targets. And as a four-hit hypothesis, this sort of goes after the first hit, which is the production of IgA autoantibodies and the galactose-deficient IgA in the hinge region. So BAFF and APRIL are really interesting, and we're learning more and more about these. So the drug that we're going to talk about here is called sibeprenlimab, which is now conditionally FDA approved. And there's a second drug in the pipeline likely to be approved sometime this year called atacicept. And what they do is they target proteins called BAFF and APRIL. APRIL and BAFF work on B cells to, one, have plasma cell survival, and 2, allow the B cell to have class switching so that they make IgA. And so when we look at the clinical trials, we're going to see that the patients get very low levels of IgA and IgG and other subtypes. And so that really limits the ability of all the autoantibody generation and then deposition into the kidney. It really takes a proximal approach. And as Kenar mentioned, the traditional therapies that we've had prior to this, not including steroids, and also complement, which we'll talk about later. This really hits a proximal portion. So I'm very excited about these drugs as possible therapeutic options for our patients. And now we actually have the ability to give them. So sibeprenlimab affects APRIL, and atacicept affects both APRIL and BAFF.
All right. Some people might even call it hit 0 because it's even way before hit 1. And
Hit
that
0.
some people are actually calling this now the 5-hit hypothesis. So starting at 0. Maybe Ali can tell us a little bit about the 2 trials in the BAFF-APRIL world, and then we'll go into the complement part.
Yeah, so I'll start with atacicept. 2 main trials to hit on there, no pun intended, are the Origin 2 and 3. So as Dr. Sparks mentioned, atacicept is a BAFF and APRIL inhibitor. It's a fusion protein, and it's provided as a once-weekly injection. So the first trial that came out, the phase 2 trial, Origin 2, enrolled 113 participants, and each of these patients received varying doses of atacicept, 25 milligrams, 75 milligrams, or 150 milligrams, or they received placebo. And what they found was at 24 weeks in the combined atacicept group, patients had a 25% reduction in proteinuria compared to placebo, and this was sustained at 36 weeks. They also showed that patients had a 60% decrease in galactose-deficient IgA circulating antibody levels as well. And so following this phase 2 was an open-label extension study, and patients were able to receive 150 milligrams of atacicept for an additional 60 weeks, so 96 weeks total. And again, patients showed a sustained reduction in proteinuria, this time 52%. There's also reduction in hematuria, circulating galactose-deficient IgA1 levels, all at 96 weeks. And I think a key finding here as well was the slope eGFR data. The average was 0.6 in the treatment group. So patients overall had stabilization of their kidney function while receiving atacicept. And so, of course, this phase 2 trial lent itself to the phase 3, Origin 3. This is ongoing. It has 203 patients enrolled, but we do have an interim analysis published for this. The inclusion criteria were adult patients with IgA nephropathy, biopsy proven, at least 1 gram of proteinuria, an eGFR of at least 30, and then well-controlled blood pressure less than 150/90, and on maximally tolerated and stable dosing of ACE inhibitor or ARB. And what this study is showing is that patients on atacicept had a 45.7% reduction in proteinuria compared to 6.8% in the placebo group. And additionally, more than 80% of patients had reductions or resolution in hematuria compared to 20% in the placebo. Now, we don't yet have slope eGFR data for this. As I mentioned, we just have the interim analysis, but I anticipate that'll be coming out fairly soon, and I'm very excited to see what that shows.
Okay, a fun question. Do we all accept that it is atacicept or is it atacicept? What do we decide?
I had this internal debate because TACI is technically the receptor,
It's
right?
TACI,
And so I would
yes.
have said atacicept, and then I went to ASN and everyone was saying atacicept, so I retrained my brain. I'm happy to retrain it back.
I don't know, actually. I'm just asking.
I did a podcast with some of the investigators and they corrected me. They like to call it atacicept. It does sound like it's
It attacks.
attacking. So
Yeah.
I don't know if that's why they decided that instead of atacicept, which is not as forceful.
Just call it attack and Sibi.
Sibi. I like Sibi.
Sibi is good.
Now I'll go with Sibi all the way.
Do you want to talk about Sibi?
Yeah. Let's talk about Sibi. Okay.
Sibeprenlimab is a monoclonal antibody that's directed towards APRIL. And this was a phase 3 clinical trial that's now published, and this now has conditional FDA approval, unlike atacicept, which likely will have approval soon. This was a very similar inclusion criteria, about 150 patients in the Sibi group and about 168 in the placebo group. The individuals had a proteinuria of about 1.3 grams on 24-hour urine, and they received this drug. And then this is the interim analysis. Again, we do not know the slope eGFR data because how these drugs are approved now, they can get conditional approval once they meet the proteinuria outcome, and then they can receive full approval once the eGFR slope data is seen after 2 years, and they have a favorable safety profile. And so this drug, SIBI, resulted in a 50% reduction in proteinuria at the interim analysis, and this was sustained throughout that entire period. As we mentioned, this is, I guess we're calling it hit zero now, and you have really profound diminished galactose deficient IgA, almost a 60% reduction after about 12 weeks or so that's sustained throughout the entire period. And also importantly, almost a 98% reduction in APRIL levels. So this really is doing its job. The adverse event profile looked really good at this time point. There were concerns that with these drugs that you might not have a good response to vaccinations. From my discussions with individuals that are involved in these trials and also some experience using these in the oncology literature, you can have a good response to immunizations, but that really hasn't been completely explored. So I think that this is another great example of really having a targeted therapy hitting really proximally for this disease. And I think it's really exciting. And I'm very excited to see where this heads.
This is so cool.
Both
Like,
of them are sub-Q injections. One is once a week, the other is once a month. SIBI is once a month.
Yeah, once a month is also very convenient. So I agree that these are really changing the way we deliver care.
I don't know which one's going to be better. I don't know if Koyal has any thoughts, but blocking both APRIL and BAFF would be better, or just blocking APRIL. I don't know which one will be better in IgA down the road.
I have a sense that both maybe, because if you think about just April, April doesn't attack the both. This is a great segue for our listeners. There are 3 receptors. There's a TACI receptor, there's a BAFF receptor, and there's a BCMA, I believe, receptor. And the BCMA and TACI are blocked by April and BAFF both. But the BAFF receptor is only blocked by BAFF, essentially. And I wonder, you're blocking more. So dual blockade might be better, but I don't really know. Like, none of us have a head-to-head analysis of any of these drugs to really know what's going to happen.
One of the things I was really intrigued about is with the long-term atacicept data on eGFR stabilization. And that's going to be really impressive to see that it almost makes their eGFR slope to normal. And that is going to be a game changer if that really holds true when we see the data coming forth, right? But I agree, it's unclear which is better. It makes sense that 2 is better than 1, but we don't know.
Should we move on to the complement?
We must move on
Oh,
to the
there's
complement
complement.
cascade. Oh no, I'm
Yeah.
up, and you will understand when you listen to the C3G podcast.
Yeah. One day April might compliment you.
My dog is named April, so I just want to make sure that that's something else to note here.
I will
Morning.
also say this is completely random, but I can see Matt, and every time he speaks, his dog just leaves the room. And so this has happened every time I've seen him talk. But anyways,
It's like I've heard this.
You'd like the dog's probably like IgA again.
I'm leaving. So cute. So let's talk about the complement cascade. I'm not going to go into details. Typically, when we think about antigen antibody binding and we think about that as a trigger mechanism, we think about classical pathway. However, that's not quite so true for IgA. There's some controversy that in IgA nephropathy, you have more of an alternative complement pathway and or lectin pathway that are affected. And that is why we're thinking that some of these complement blockade agents that we'll talk about next might actually be beneficial. And so briefly, we all have the C3 takeover mechanism where we have our alternative complement pathway partly active. And if there's a bigger trigger, it will get ramped up. And if you had a mutation genetically, which is a little bit less common than a functional problem where you have some nephritic factors or something that is now causing increased activity of this alternative complement pathway, you can imagine that you have this whole cascade that's almost always active. And that can affect from C3 to C5 to the terminal complex that is formed, like the soluble MAC complex. So really, let's talk about the complement drugs that have come in the world of IgA nephropathy, and where do we go from there?
So the main drug that we covered in NephMadness that we can talk about today is iptacopan, and this is a complement factor B inhibitor. So it specifically is going to target that alternative pathway. The data we have for iptacopan is the APPLAUSE study, so I can go into that a little bit right now. This enrolled 443 patients, again with biopsy-proven IgA nephropathy and at least 1 gram of proteinuria over 24 hours despite optimized supportive care. And again, a GFR greater than 30, although the study does mention that there will be data for patients with reduced GFR as well in the future. Of these 440 patients, 222 received iptacopan and 221 received placebo. And this is dosed at 200 milligrams twice daily. It's an oral pill. And what the applause study showed was that at 9 months, proteinuria levels were lower in those receiving the complement inhibitor by 38%, so clinically and statistically significant. And importantly is to know that there was really no significant difference in adverse events between the two groups. When we think about complement inhibition, we do worry about infection risk, particularly encapsulated bacteria. And it's important to know that there are ways to mitigate this risk clinically when prescribing the drug, and that ultimately we can be reassured about the safety profile of this medication.
Thank you so much, Ali. Really appreciate it. You mentioned a little bit about the vaccination requirements and the risk with encapsulated bacteria. Matt, do you want to talk a little bit more about that for our listeners?
Yeah, this is a lot of complement discussion today. And if you listen to our other podcast on C3G, it's very similar. This is the same drug. The encapsulated bacteria really require the complement cascade to get rid of it, so that when you don't have that system and you block it with this drug, you're going to be at risk for a meningitis, streptococcal infections, and Haemophilus influenza. So getting those vaccinations is very important. They recommend that you get these vaccinations at least 2 weeks before starting the drug. And at least for IgA nephropathy, you might be able to time that with the patient. And so you need to get serotype A, C, W, Y, and B. Those are the meningitis vaccines. And there's a little bit of difference in how, when you actually give them. And you need to get boosters as well. You need to get the pneumococcal vaccine. And the good thing is we have the new conjugate vaccines, which are really great. Make sure they have their Haemophilus influenza vaccination as well. Now, if you can't time it and get these vaccinations before you start the drug, you should still do the immunizations, but you can also give antibiotic prophylaxis. The preferred is PenV, or if you can't take that, then you can take ciprofloxacin. And so that's another really important piece here. The last thing is that you need to really monitor them for signs and symptoms of infection while they're on this drug, and let them contact you. And if they have anything, they need to have some prophylactic antibiotics as well. So yeah, this is a really important topic. And I think as a nephrologist, we start to dive more into the complement cascade. We're going to see more and more diseases that we're going to be treated with complement cascade blockers. And as we already mentioned, they've already got 2 new diseases, and then we're going to keep adding and adding down the road.
Just one more thing, because people, I'm sure, have used iptacopan now for IgA or C3. It's important to monitor lipids, as a lot of people who have hyperlipidemia at baseline, or you develop nephrotic syndrome with the setting of IgA, they will get hyperlipidemic. And with iptacopan, you might want to add a statin along with that if they're rising lipids at the same time. So just something to monitor as well, as we have seen that in practice.
So the question on everybody's mind is, which group wins? And the reason I'm bringing this up is because I want to go last. And I do not want to give Matt the chance of going last for this question. So we are going to start with Dr. Sparks, because he went last.
Okay. To me, the winner is the BAFF-APRIL inhibitors, the new B-cell modulators. And going after hit 0 sounds like that's where we need to go. So I'll stop with that. I'll say I'm all the way team BAFF and APRIL. And my dog's named April, so I have to do that.
Okay, Dr. Tomasi, you're next.
I am team BAFF-APRIL too. I promise I'm not just saying that. We talked about the 4-hit hypothesis. We're going to hit 0, hit -1, hit -2. Pathophysiologically, this makes the most sense. And really, the data from Origin and from Visionary are really compelling. My vote goes for the B-cell modulators as well.
Okay. Dr. Jhaveri.
I think for me, it's pretty slam dunk that it's going to be BAFF-APRIL inhibitors. I think they're going to be like the hydrochloroquine of IgA. They'll be for most patients. And iptacopan, steroids, and budesonide can be used as like when you have flare-ups. But these APRIL BAFF inhibitors are going to be your drugs to stay for chronic management of IgA to decrease the whole flare-up process.
Oh my goodness, it's my turn. And the reason I went last is because I can't decide. I've actually been like torn between the two of them.
I thought you had some insider information.
I do not have any insider information. My insider information is you, actually. So
maybe you can go against the grain here.
I will. Yeah,
we can go 4 for 4. 4 hits
No,
for bad.
Yeah.
I genuinely am. The reason I'm conflicted is because one, BAFF for all of the reasons that you've talked about, the B cell modulators. But the thing about the complement inhibitors is that they can be used for so many of the diseases right now.
But
right?
we're talking about
they-
IgA.
I know we're
Yeah.
talking about IgA, but in reality, they help so many patients. It's not just IgA. They help so many
Poor
patients.
complement system doesn't even need to be on anymore.
I don't think any of these will win the whole thing. Any NephMadness, so just
And
well,
Oh,
so
come
I can decide
on.
whichever
Not
one, and
really
it's
that-
good.
Oh,
There's
that's
nothing
interesting
to it.
because we have actually the complement could be against each other in the finals.
Ooh, that
That'd
would be
be
so
fun.
cool.
be interesting.
I'll watch that. Yeah.
So you've got to make a decision. This is really important. All
I'm going to
waiting.
go against the grain then. Let's not do
Oh.
4 for 4. Let's do
Ooh.
complement inhibitors.
Oh,
I
okay.
respect
I will,
that.
Any
and I will
rationale?
say
You have
only
anything
because
that we can
somebody has a
hang-
flare up. I don't want to give them steroids.
Love it. I like that.
Yeah.
That's legit.
Okay, with that, thank you everybody for listening to us on this amazing NephMadness episode on IgA nephropathy. I would like to thank Dr. Sparks and Dr. Tomasi for joining us. And Kenar and I are going to sign off. Thank you again and have a wonderful day.
Thanks so much.
Thank you.
This has been GN in 10 from the International Society of Glomerular Disease. You can listen and subscribe wherever podcasts are found and tweet at us at ISGD Tweets. Thank you for joining us.
This one will be a lot easier.
Oh, wait, what? Who was next?
It sounds like a drink.